911. This is a singular number that holds a high degree of importance in the American culture. American citizens call 911 when they are at their most injured and vulnerable, and expect that first responders who answer their calls for help can fix their emergencies. These people are often looking for emergency medical providers to provide care in their acute medical and traumatic injuries. The expectation is that all potential patients will be treated with the same quality of care, no matter how the patient identifies. However, this does not seem to be the case. My name is Taylor Dwall. I'm currently one of your peers in your Health Disparities in the U.S. class, and in my semester final paper, I dove into the world of health disparities that are seen in emergency medical services. This is a topic that is near and dear to my heart, as I've been working in pre-hospital emergency medicine for 3 years, both as a firefighter and as an EMT. It was my initial belief that every patient was treated equally, regardless of who they are, but the data seems to be showing otherwise. The standard that was drilled into prospective EMS providers is that you should treat all patients with the highest standard of care. You shouldn't always treat your patients with the same level of care you'd want to treat your family members with. But the data shows that there are discrepancies in the quality care that we are providing to our patients, and that is affected by certain identifiers such as patient race, ethnicity, and even socioeconomic statuses. Internal department reviews across the United States are finding that there are cultural disconnects between providers and their patients. And this may alter the level of care that is provided to them. For our minorities, we often see discrepancies in the form of lack of cultural competency and miseducation about general minority physiology. In 2018, 76% of certified EMS workers in the USA were male, and 85% of them were white. This lack of diversity in the field leaves providers with poor cultural competency. These providers encounter barriers such as language barriers and cultural beliefs that differ, which may hinder their ability to identify any problems in their patients. Additionally, there is gross misinformation about the physiology of minorities. There is a common misconception amongst providers that there are medically relevant physiological differences with minorities, but this is not actually the case. This has been observed in a 2016 study where white medical students and doctors were asked to review statements regarding biological differences between black and white patients, with some examples listed above. Most doctors agreed with these common medical myths, which has implications that these doctors could end up withholding pain medications due to these preconceived biases. And this could result in negative patient outcomes. The implications for this study were seen in an Oregon case review looking at 25,000 charts of EMS providers and different minority patients. The study showed that black patients were 32% less likely to receive pain management medications than their white counterparts. Asians were 24% less likely, and Hispanic people were 21% less likely. And this is despite reporting the same level of pain as the white patients. Another population that faces healthcare discrepancies is the homeless population, low-income populations that providers respond to. The phrase that health equals wealth rings true, as frequent callers 911 tend to be of lower socioeconomic class. This is due to their inability to have access to things such as preventative health care. These frequent calls typically result in providers growing apathy towards them as they develop compassion fatigue, as it may seem that these callers are not helping themselves. But in reality, these patients are incapable of helping themselves. This growing apathy means providers are more hesitant to do interventions in the patients, as they do not believe that they are actually in need of assistance due to the sheer volume of times they have called. This results in negative patient outcomes, as pertinent diagnoses are often missed in the field. This can be seen with staggering statistics such as LA Fire Department statistics that show that they respond 81 times per 1,000 people to the total population, but the compared ratio of homeless people is they respond to 1,135 calls per 1,000 homeless residents per year. So how do we fix this? For the observed racial biases that we have, we should hire more diverse personnel that reflect the communities that they serve. Then these people may be able to overcome any barriers to care that they may encounter. The next solution is to ensure that the next generation provider is not taught medical myths that have negative effects on minorities. And we also need to provide continued education for line personnel so we can stop perpetuating these medical myths. As far as the socioeconomic solutions, the best solution to the low socioeconomic class that keeps calling and the homeless population that keeps calling is to provide them with what is called community paramedicine. Community paramedics often make house calls and reach out to our frequent flyers to give them preventative health care practices, refill prescriptions, and just generally check on their health. This will reduce the number of 911 calls, as they will be having preventative care provided to them as a service for the city instead of having to call 911 to go to the emergency room for their care. This will reduce the volume of calls that 911 personnel have to these patients, and thus they will have less apathy towards them and will be more likely to treat them appropriately. So in conclusion, though EMS personnel are taught otherwise, they subject racial minorities and persons of lower socioeconomic classes to healthcare disparities. However, this can be fixed both by hiring more diverse personnel that reflect the communities that they serve, as well as by continuing to educate people on the medical myths that are being practiced right now. Additionally, we can help fight provider apathy towards the homeless population by providing community paramedicine programs. These community medics can go reach out to these frequent flyers before they call 911 and provide them with non-emergency medical care that can be preventative in nature, as well as by giving them medications to help assist in their issues. Attached are my references below, and I hope you guys have a great day. Thanks for listening.